there's really quite a bit of excitement around these bispecific T-cell engagers. We at ASH saw maybe 6 to 7 presentations on different phase 1/2 trials in patients receiving these bispecific T-cell engagers. Most of them were targeting BCMA and CD3, where basically the bispecific anchors onto BCMA of the myeloma cell and then activates CD3 with its other binding domain. And these therapeutics all differ in the way they actually bind to the myeloma cell, but they all differ in the level of T-cell activation that they can cause. Now, the activation of T-cells, if you cause less activation of T-cells, you may have lower amounts of CRS and lower amounts of neurotoxicity. It may be a lower response rate. Whereas if you activate CD3 more aggressively, maybe you have a little higher CRS and you have a little higher neurotoxicity rate, but maybe you'll see an increased response rate. We don't really know the truth of that statement. What we need to find out is with each one of these agents, what is the side effect profile and what's the response rate and how durable these responses are. I'm very impressed with some of the patients that we have on bispecific T-cell engagers at our institution that are literally 18 months, 24 months, more than 24 months down the road, and are still receiving therapy and are MRD negative and have had sustained MRD negativity despite having 7 or 10 prior lines of therapy. These are very active agents. This is single agent activity. And I think in the bispecific T-cell engager space that we can do sequential therapy. We haven't had a great history of doing sequential therapy for myeloma. What I mean by that is choosing agents like lenalidomide and dexamethasone and doing that for 6 months, and then switching to maybe a PI like bortezomib and dexamethasone for 6 months, or doing one triplet and switching to a different triplet, something like that sequentially. That hasn't really amounted to much benefit in the myeloma space. But with T-cell engagers, I think there's a distinct possibility that this may, in fact, have a much better response. That said, we have to see after 6 months of therapy of one bispecific, maybe that binds to BCMA. If there's disease present, maybe we have to go after a different cell surface marker. Maybe we go after GPRC5D, or we go after FCRH5. And so we can do these sequential therapies now, in my mind, with a more targeted approach. And I think we're going to have more success. These bispecific T-cell engagers, I think they're really going to blanket the myeloma treatment spectrum. I think we're going to try them in smoldering myeloma. These are therapeutics that are not chemotherapy, right? They're immunotherapeutics. They're only advancing and augmenting the immune system. And so they'd be less apt to cause things like secondary malignancies, et cetera. And so they're just trying to augment the effects of the local environment, the local T cells, get them to do the job. So I think in smoldering myeloma space is a great space to test these bispecifics. And I also think they're a great space to test them in frontline therapies, both in transplant eligible as well as transplant eligible. I think it's a great possibility that they can work well in maintenance after patients receive induction, potentially a CAR or an autologous transplant. And then if they still have residual disease, receiving a T-cell engager to mop up the residual disease, hopefully again to provide a durable response. And I think they can be used in early relapse as well as late relapse. And if I was to picture 10 years from now, I'd say they're going to get a BCMA targeted therapy up front. They're going to get a GPRC targeted therapy at relapse, and they're going to get something else, maybe a FCRH5 at later relapse, or a novel target that we haven't identified yet. And that you're going to go from bispecific to bispecific to bispecific, and maybe throw in a CAR or some other novel therapy in the interim. But I think it's really going to blanket the space.